5 common mistakes I see again and again when providers respond to a delirious patient in the hospital. Watch to the end. I'm going to teach you how to avoid these mistakes and how to confidently and efficiently handle delirious patients in the hospital. The discussion today is applicable to non-ICU settings and hyperactive delirium. Let's start. The first mistake I see is not to warn the patients or their families about the possibility of developing delirium in those who are at high risk for that. Delirium technically can happen in any patients admitted to the hospitals, but elderly patients, particularly those with dementia, are typically at high risk. I still remember the face of a frightened lady I've encountered one morning. She just got into the hospital to visit her husband and found out he was confused and did not even recognize her. She literally asked me, "What have you done to my husband? He was completely fine yesterday." That was my first encounter with the patient and the wife. He was admitted the day before. Had the admitting physician explained the possibility of delirium to the patient and his wife, her response would have been way different. I typically tell them there is a possibility the patient may develop episodes of restlessness, confusion, and even sometimes agitations while in the hospital, which can happen to anyone because of the different hospital environment, not sleeping well, and different medications, which may miss the chemicals in their brain. Then I tell them that we will try our best to prevent that from happening, and here I lay out the patient size of my delirium prevention strategy. I ask them to spend as much time as they can with the patient, and I even ask them if someone can spend the night with them. I also ask them to provide daily orientation and redirection, including reminding the patients about where they are, why they are in the hospital, what's the day, time and date, etc. I ask the patient to wear his or her eyeglasses and hearing aids, of course, if he or she uses them, all the time except when they typically take them off at home. I ask them to keep their windows shades open during the day, and I ask them whenever appropriate to eat well and stay hydrated. And this brings me to the second mistake I see, which is the failure to provide a strategy to prevent delirium from our side. We already mentioned what we want the patient and family to do. From our side, we should try the following. Remind the patient and their families daily to do the things we just mentioned earlier. Also, daily remind the nurses to provide orientation and redirection, and to provide that ourselves as well when we round on these patients. Please make sure that we write the day and the date on the wall, and make sure it's large enough for the patient to read. A wall clock to tell the time is highly recommended. Consult physical therapy on day one. Try to get them daily out of bed. Have them sit next to the window and encourage ambulation. Minimize any sleep interruptions by setting vital signs check frequency to Q8 hours if possible. Have labs drawn at 6 a.m. or later if possible. Avoid or minimize the use of anticholinergics like antihistamines. Avoid or minimize the use of benzodiazepines. Address pain control promptly, preferably with non-opioid analgesia. Please minimize the use of narcotics if possible. Avoid constipation or urine retention. On your daily round, check for bladder distension and ask about a bowel movement. And avoid or minimize the use of medical equipment like oxygen, Foley catheters, and please remove them as soon as possible if the patient becomes delirious, of course, if possible. Believe me, these prevention strategies are powerful and they do work, so please use them. The third mistake is not to ask for a full set of vital signs and a blood sugar check when called about a delirious patients, whether hyperactive or hypoactive delirium. Most patients actually will alternate between hyperactive and hypoactive delirium, sundowning and agitated at night, lethargic and obtunded during the day. Remember, most, not all of them. So why is it important to get a full set of vital signs and a blood sugar check? Let me tell you this quick story. A patient in his 60s who was in the hospital and became confused and agitated. The nurse called the resident who was on call, and a dose of haloperidol was given. 30 minutes later, the patient was getting more confused and agitated, and another call to the on-call residents, and this time a dose of lorazepam was given. 10 minutes later, code blue was called. And and sadly the patient was pronounced dead 20 minutes later. This is a real life story. The case was investigated and they found the patient was hypoxic during this period, an issue that was not addressed at all. So please always ask for a full set of vital signs and blood sugar checks to detect any possible life-threatening conditions that can trigger delirium. It's also prudent to check the most recent labs to check for any major electrolyte disturbances which can also trigger delirium. The fourth mistake is with the way we give or administer antipsychotics. Give me your attention here. Antipsychotics should be reserved for those with severe agitations, not mild agitation, severe agitations who fail to respond to adequate reorientation and redirection with no other clear reversible causes. Remember, using antipsychotics for this indication is an off-label use as currently no medication is approved by the FDA for the management of delirium. Mildly agitated and restless patients should not be given antipsychotics. Just provide them with reassurance and redirection. It works. Make sure also to provide full precautions and to discontinue fully catheter if possible. Antipsychotics are better given as a one-time dose rather than PRN for the following reasons. With PRN, patients may get antipsychotics even if they are mildly agitated or restless, as this will leave it to the patient's nurse clinical judgment. And I have to admit, most our nurses have excellent clinical judgment. Antipsychotics should be used for the shortest time possible as they are associated with increased mortality in patients with dementia. Antipsychotics are considered chemical restraints that may delay patients' discharge to rehab or nursing homes in the United States if it is mentioned on the patient list of medication, even if it's PRN. Now pay attention here. One trick I do, if despite everything the patient continues to have sundowning and agitation, particularly if the patient has received antipsychotics twice or more, I start a scheduled daily oral antipsychotics to be given right before sunset. For example, I would give Seroquel 50 mg POQ daily 1 hour before sunset. Please discontinue that as soon as delirium has improved or resolved, typically within 24 to 48 hours. Let's quickly go over the commonly used antipsychotics in clinical practice. Haloperidol or Haldol, Ziprasidone or Geodon, Olanzapine or Zyprexa, Risperidone, Quetiapine or Seroquel, Aripiprazole or Abilify are the ones you will see mostly in clinical practice. All come in oral forms. Haloperidol and Ziprasidone, also Olanzapine and Aripiprazole Abilify come in IM form as well. Please avoid using IV form because it's associated with clinically significant QT prolongation. Now, all of them can prolong the QT interval, but Aripiprazole Abilify is the one with the least effect on the QT interval. Haloperidol is the oldest and remains the most popular one. The rest belong to the new generation of atypical antipsychotics. Ziprasidone or Geodon probably is the most commonly used in this group, particularly the IM form. For acute agitation in non-ICU settings, we can use Haloperidol 0.5 to 1 mg IM. Remember, the maximum daily IM haloperidol dose is 5 mg per day in non-ICU settings. In ICU, we can give higher doses, 2.5, 5, 10 mg to a maximum of 30 mg a day. The dose can be repeated every 30 minutes until the patient is calm or we hit the maximum. Ziprasidone or Geodon can be given in 5, 10 or 20 mg IM. Repeat every 2 hours until the patient is calm or we hit the maximum. Remember, the maximum daily IM Ziprasidone or Geodon dose is 40 mg a day. For oral agents, Quetiapine or Seroquel 50 mg Q daily is my preferred oral agents. Other agents include Olanzapine 5 mg Q daily, Ziprasidone 20 to 40 mg PO BID, Abilify or Aripiprazole 5 to 10 mg Q daily, and Risperidone 0.25 to 0.5 mg twice daily. In ICU settings, which I talked about it in previous videos, the links are below, Precedex drip is increasingly used for hyperactive delirium. Now, if antipsychotics are contraindicated or the maximum dose is reached, benzodiazepine can be alternatively used, but for the shortest time possible, as they are associated with worsening confusion and agitation once their effect wears out. Lorazepam 1 to 2 mg IV can be used. Precedex can be used in ICU settings as we just mentioned. Please avoid using sedatives, antihistamines. Please do not continue antipsychotic medications upon discharge. Just stop them. Cholinesterase inhibitors like rivastigmine should be avoided. They do not work. The fifth and final mistake is to use physical restraints inappropriately. Physical restraints should be the last thing to use as they likely will worsen delirium as the patient becomes very frustrated with them trying to use his hand or her hand and he cannot. Try to resist placing restraints, and if you do, please discontinue them as soon as possible. A safer alternative is to have a one-to-one setters or having a family member in the room. That can be extremely helpful. In the end, if you find this video useful, give it a like and share it with your colleagues. For those who signed up for our video PDF summary, the summary of this video will be delivered to your email 24 hours after the video is released on the channel. If you have not signed up for the PDF summary yet, you can do so using the link provided below. Thanks for watching.